Hello everyone, I'm Sheila Sheth from Johns Hopkins University in Baltimore, and my lecture today is going to be on ultrasound evaluation of adnexal masses. We're going to talk about evaluation of adnexal masses, and really ultrasound play a key role in the detection as well as characterization. And before we start the lecture, I want to read you this quote from my colleague Dr. Mitra Patel from Mayo Clinic. Because it's really, key to understanding what we need to do with these adnexal masses. So he wrote, "The radiologist who merely measures the size of the mass and subsequently offers a differential diagnosis that includes nearly every adnexal abnormality, including malignancy, has failed in his or her opportunity to contribute meaningfully to the care of the patient." So when we see an adnexal mass, we really need to be able to determine what we think it is going to be. And what we need to consider, in addition to the sonographic characteristics, which are obviously very important, we need to also consider the age and the menopausal status of the woman, if there are any associated clinical symptoms, and if there are lab abnormalities, for example, CA125, and put everything together to offer a diagnosis or a differential diagnosis. So ultrasound is widely accepted as a first imaging modality, and we use endovaginal as well as color and power Doppler. And several papers, even recent papers in the literature, have shown that expert sonographic interpretation is highly accurate in differentiating between benign and potentially malignant masses with very high negative predictive value. So for example, you see this echogenic mass in the ovary, and we'll discuss it in more detail later, but we can say with pretty good confidence that, with a shadowing, that this is very likely to be a cystic teratoma. With MR, so MR is a very important problem-solving modality for characterization of adnexal masses that are indeterminate for ultrasound. And it has high sensitivity and high specificity as well for identifying malignant and benign masses. And it's helpful in characterizing some masses like this one, and we'll discuss this one later again in the lecture, so I'm going to reserve the diagnosis for now, to characterize it. It's indeterminate on ultrasound, and then we can make a diagnosis with MR, and we'll come back to that case later. CT is really helpful in staging of known malignant ovarian lesions, so staging of ovarian cancer. As you can see here, showing the extra adnexal carcinomatosis and the ascites, in addition to this mixed solid and cystic mass in the pelvis. And it's helpful in characterization of some ovarian masses, such as dermoid, by detecting the fat within them. So the objective of this talk then is to illustrate key sonographic characteristics of benign ovarian lesions, review the sonographic criteria that will help answer the question, is this mass likely to be an invasive ovarian cancer, or is it likely benign, and discuss some indeterminate ovarian masses on ultrasound and how we need to follow up for management. And we'll end up discussing how to formulate a clear conclusion in the ultrasound report and offer appropriate recommendations. Is this mass benign? Can we offer a specific diagnosis? Is this mass indeterminate, and should the patient have MR or perhaps laparoscopy? Or is this mass likely malignant, and then the patient will go on CT and GYN oncology refer on staging laparotomy? So ultrasounds will be very helpful in sort of triaging and helping in the proper management of the patient. So first, let's talk about benign adnexal masses that we can really diagnose with, pretty high degree of certainty. And the first thing we're going to talk about is ovarian cysts in premenopausal women. It is the most common ovarian mass, and I have mass in quotation because it's really not a tumor. They can have simple cysts, which basically result from failure of the follicle to the Graafian follicle to involute. You can have hemorrhagic ovarian cyst, likely resulting from failure of corpus luteum to involute. These sometimes are symptomatic, where the simple cysts tend to be detected incidentally. And occasionally, they can rupture and cause a hemoperitoneum. And finally, in this category, we should also put Theca Lutein cysts with results from hyperstimulation of the ovaries, and either iatrogenic hyperstimulation or associated with gestational trophoblastic disease. So the ovarian simple cyst, like this one, so it's completely anechoic, thin wall, is the functional cyst, very, very common. It's really, we don't need to do anything about it in most cases. And notice this is a corpus luteum. Notice the high vascularity around it. So I don't even report this. You can put in the body of the report, sometimes there's a corpus luteum, but I really don't. This is a normal finding in a premenopausal woman. These are good example of hemorrhagic cysts. So basically it's this corpus luteum that fails to involute and kind of grows. And so these are characteristic appearance of hemorrhagic cysts. The most commonly described is this characteristics lace-like appearance, which is diagnostic of a hemorrhagic cyst. Again, you have to make sure it's a premenopausal woman, of course. And then if we put color Doppler, you can confirm that this is indeed a cystic lesion because there is no flow within this portion. This is just a clotted blood, basically. You may have flow at the periphery of the lesion. Or you can have this appearance of a retracted clot. And notice that although this looks like a solid component of this mostly cystic mass, the border either straight or concave. And so a tumor nodule would never have this kind of straight or concave border. And if you want, you can confirm it by seeing no flow within that area. Perhaps a little bit less commonly, you can see a blood fluid level. As you can see here, this is blood that's starting to coagulate, and there is still some more liquid blood here. So these are very characteristic appearance that allows us to make a confident diagnosis of hemorrhagic cyst. So what do you do with these cases? Well, if they're 5 centimeters or smaller, there is no need to follow them up. If they're more than 5 centimeters, the SRU guidelines currently recommend follow-up ultrasound in 6 to 12 weeks, and you want to do a relatively short-term follow-up, 6 to 10 weeks, because if you follow the patient in 6 months, then the patient may have another hemorrhagic cyst in the same ovary, and you would not know whether it's a new lesion or the same one. So 6 to 12 weeks are a very important interval. If you see an ovarian cyst on CT, we can use the same rule. We don't need to recommend an ultrasound right away to confirm that this is a cyst. If there are atypical appearance, for example, in this case, this was a mostly echogenic mass, and so it's not a typical appearance of a hemorrhagic cyst, and in this case I would also go with a follow-up, and the patient came 4 weeks later actually, and that lesion was gone, and there was just a little much smaller residual lesion. And these are examples of Theca Lutein cysts, which are also in this category of kind of functional cysts. The patient up superiorly had a molar pregnancy. You can see the markedly distended uterus with the cystic spaces, and she had bilateral enlarged ovaries, markedly enlarged on the left here with multiple cysts. And then the patient here at the bottom was a patient following hyperstimulation with, again, markedly enlarged ovaries. The next lesion that we can readily diagnose with confidence is endometrioma, and it will appear as a well-defined cystic ovarian mass with smooth wall. And the characteristic diagnostic feature are these diffuse low-level echoes. The mass may be multilocular, and the locules may have variable internal echoes because these bleed periodically at different times. The other thing to look for in endometrioma, these small echogenic foci in the wall, echogenic foci here that may be resulting from hemosiderin deposits. And occasionally the appearance overlaps with hemorrhagic cysts, but usually this diffuse low-level echoes is a very important feature to diagnose endometrioma. This is another example of a patient who has a relatively large endometrioma, and you can see this is multilocular with an anechoic component, but the other component is this diffuse low-level echoes, very characteristic of endometrioma. The patient also happened to have an MR where actually there are bilateral endometriomas, and they're characteristically bright on T1 and then have this T2 shading, again due to the hemosiderin content on T2. But be careful. Look at the entire lesion. This is a lesion which also in the ovaries, also diffuse low-level echoes, but there are little nodules here. And so this you wouldn't want to see with an endometrioma, so you shouldn't call this an endometrioma. And this turned out to be a 61-year-old woman in addition, so that she wouldn't fit the demographic profile, and this surgery was a borderline serous tumor. So again, it's very important to look at the entire lesion. Now let's start with a case now to segue to the next lesion we can diagnose with confidence. This was a 56-year-old woman with breast cancer, and she had an adnexal mass that was incidentally detected. We were doing the ultrasound to assess her endometrial stripe, and you can see here that this patient has this mass in the ovaries and these very bright lines, echogenic lines within the lesion. This is a characteristic appearance of the dermoid mesh in a cystic teratoma. It is postulated these are hair floating in the sebum, and so again we can make a diagnosis of dermoid cystic teratoma very comfortably, and this is another lesion that we can really diagnose confidently. So cystic teratoma or dermoids represent about 15 to 25% of ovarian neoplasm. 10 to 15% are bilateral. Typically they're going to be found in young adult women. It's one of the most common tumor of the pregnant woman. However, some of them are never detected until after menopause. So 8 to 10% of dermoids are actually found incidentally in postmenopausal women. These are tumors who derive from the 3 germ cell layers, and they have characteristic ultrasound features. They have a variable component of these features. So they can have a dermoid mesh that we just saw, or you can have an echogenic mass within the ovary with shadowing, the so-called tip of the iceberg sign, or you can have a mass with a dermoid plug, which will have calcifications, or, and less commonly, but this is a very cool appearance, they may have a fat fluid level with floating echogenic balls. And if there are 2 or more of these signs in an adnexal mass, as Patel showed a long time ago, there is a 100% positive predictive value for cystic teratoma. So we're going to look at some example. This is an incidentally found relatively small. This was 2 centimeter, very well-defined echogenic mass in the ovary. This is a little bit larger mass. Notice that it is also echogenic, but there is shadowing, and the shadowing can come from fat mixed with hair. Or these are two cases of cystic teratoma, very large mass with a fat fluid level and a hairball floating at the junction of the fat fluid level, as well as a dermoid plug here. And this is a CT scan in that same patient. The patient actually had bilateral cystic teratomas, and again, the fat fluid level. And another example, this was a younger patient, again, a large echogenic mass. This is the large cystic mass with internal echoes and a echogenic mass with shadowing. However, again, you have to be very careful and look at the entire mass. This is also a mass that has echogenic nodules. However, there is no shadowing. It was also an older woman, so you have to be a little bit older, 42-year-old. But these had flow on color images that I'm not showing you. Dermoids usually don't have that much flow, and this was a high-grade ovarian cancer in a 42-year-old patient. So we really have to be, again, careful, evaluate, especially when masses are large. It's very important to really look at the entire lesion. Let's move on to a different entity now. This was a 76-year-old woman with an adnexal mass, and you can see in her left adnexa, she has a simple cyst, a cystic lesion, a thin wall, completely anechoic. And so this is a simple postmenopausal cyst. And by definition, they should be 7 centimeters or less. They should be unilocular with enhanced through transmission, have a thin wall, no flow of course within it, and if there is flow at the edge, usually it's high resistance at the periphery, as you can see in this patient here. And then several literature papers have shown that when you screen asymptomatic postmenopausal women with endovaginal ultrasound, about 3 to 15% will have these incidentally detected cysts, and also women that are on tamoxifen, about 10% of them will develop a cyst as well. So this was a large study from University of Kentucky Kentucky ovarian screening program that looked at over 15,000 asymptomatic women. About 18% of these had unilocular cysts, and they followed these patients, and the vast majority completely resolved over time, 69.4%. 6.8% stayed unchanged, and a small minority developed something within it. So 16.5% developed a septum, 5.8% developed a solid areas. And out of these women, about 1% were diagnosed with ovarian cancer, but usually, it was a screening study for ovarian cancer, right? But they had other findings that developed over the follow-up period. And the follow-up period in this study was a mean of 6.3 years. So it is important to follow these patients at regular interval for cysts that are more than 1 centimeter. You want to, of course, first check the CA-125, the tumor markers, and make sure that they're normal. And then after the first follow-up yearly for several years, at least until stability is assured. So if they're stable for 5-6 years, then you're probably okay. And again, this is in the SRU consensus paper from radiology in 2010. Because the natural history of these cysts is that they stable resolve over time. Now, you have, in the follow-up study, you have to recommend surgery if the cyst enlarges, which is not that common. In the Kentucky study, it occurred in less than 10% of their cases. If there are, of course, mural nodules or thick septations, or in some cases, surgery will be recommended if the patient is very anxious about that cyst or unable to undergo regular ultrasound. And in the Kentucky study, again, some of the pathfinding that they had was either mucinous or serous cystadenoma, para-ovarian cysts, endometriotic cysts, or hydrosalpinges. Now again, look very carefully at the entire cyst, and be careful, especially of the near wall, because there are reverberation artifacts in cystic lesions that you want to make sure that there is not a little nodule which would put this cyst in a different category, hiding in that reverberation. So this is reverberation artifact here, but this is a different patient that had a cyst. But if you look here, this is not reverberation artifact, because if you look even on the side of the wall, there's a little nodularity here. Another view again showing the nodularity, and this was a patient that had an elevated CA-125, and this was a small ovarian cancer. So again, we have to be very, very diligent about looking at the entire lesion. Now, another lesion that we can diagnose with confidence is Hydrosalpinx. It will present as a tubular adnexal mass with incomplete septations. And on the transverse view, you can have the cogwheel sign, the little thickened septae that you see, the waist sign that you can see here, like focal narrowing here. So this is a good example of a Hydrosalpinx. Again, another one here. This was a 56-year-old woman, and so it was difficult to be 100% sure this was a Hydrosalpinx. So to reassure the patient had an MR, and again, clearly shows that this is a Hydrosalpinx. So in many patients, we can diagnose these with confidence. Another benign lesion we can diagnose with confidence, a para-ovarian cyst, which will present as a separate, simple cyst separate from the ovary, usually in the broad ligament. These are congenital cysts. And then finally, the peritoneal inclusion cyst, we can at least strongly suggest a diagnosis. What happens in this patient, there's trapped peritoneal fluid in around the ovaries because of adhesions in patients who have had prior surgery, pelvic inflammatory disease, or endometriosis. Usually, of course, it occurs in premenopausal women with active ovaries, and you're going to see a cystic lesion with septation, and look for the recognizable ovary, which is within the mass or around the edges. And the other thing is, if you look, the lesion has a passive shape. There's no mass effect on the adjacent ovary. But, we can suggest a diagnosis, especially in the appropriate clinical context, and then recommend another MR to confirm the diagnosis. So in summary, benign lesions we can diagnose with certainty includes ovarian cysts, simple and hemorrhagic, Theca Lutein cysts, endometrioma, cystic teratoma, postmenopausal cysts, and oftentimes hydrosalpinges and peritoneal inclusion cysts. Now, let's answer the next question. Does this mass have malignant imaging features, or is it more likely to be benign? So there are several papers, and I'll just mention them very briefly, looking at meta-analysis of multiple studies. And the conclusion is that the performance of sonography differentiate benign from malignant mass is actually very good. And really, grayscale features combined with color Doppler, with color and Doppler spectrum, have the best performance. And not surprisingly, a combination was better than just grayscale or color or RI alone. But really, the morphologic assessment tends toward better performance than color flow. So really, the morphologic assessment of these lesions on grayscale is key, in my opinion. So it's a matter of pattern recognition, and you have a very solid appearing adnexal mass with increased vascularity and sort of low diastolic tumor vessel type flow. In addition, this patient has ascites. This is pretty clearly, no doubt, that this is going to be a malignant lesion. And this was a carcinosarcoma of the right ovary. So on color Doppler, you're going to look for the presence of those tumoral vessels. You look at the location of tumor vascularity, whether it's peripheral or central, or in soft tissue nodules, if it's a cystic mass with nodularity. And on Doppler spectrum analysis, oftentimes you'll have increased forward flow in diastole, so a low resistive index, because these are basically abnormal tumor vessels which lack smooth muscle, and there's areas of AV shuntings. And people have looked at different cutoff to suggest malignancy. I think what is important is the location of vascularity, the appearance of the spectrum, and also combine it with the grayscale appearance. But if you're going to use the RI, then do multiple measurements and use the lowest value to assume the worst case scenario. So on the other hand, ultrasound features that will favor benignity would be that of a predominant or exclusively cystic mass with a few thin septations, maybe 3 or less, no mural thickening, no flow, or very high resistance flow at the periphery of the lesion. And this was a 33-year-old woman with a serous cystadenoma. This is another example. So this would be kind of an indeterminate lesion, or we could be a little nervous, maybe recommend an MR just to confirm that there is no enhancement, because there was a couple of septation, maybe the wall here is a little bit thick, but this was also a serous cystadenoma. By contrast, ultrasound features of invasive ovarian cancer include the fact that it would be either a predominantly solid mass or, as in this patient, a cystic mass with thick wall, irregular thick septation, or large soft tissue nodules with papillary projections. There might be internal echoes. Note here the wall, even this wall is thickened here. And then there may be either central vascularity in solid masses or vascular nodules, as you can see here, with tumor vascularity with this, again, low RI-PI type of flow in this soft tissue nodule. Also look for complex ascites. And this was an endometrioid cancer. Or this patient who presented to the emergency department with abdominal distention because she had a lot of ascites, and although they didn't request it, we looked in the pelvis to try to find out why this patient had so much ascites, and she has a solid mass in the left adnexa, increased vascularity, and this was a left fallopian tube serous carcinoma. So if we see these ultrasound features, we can be pretty worried that this patient has a malignant ovarian lesion. So invasive ovarian cancer represents about 25% of gynecological cancers. There are about 26,000 new cases a year in the US, usually occurring in older women, peak at 50 to 60 years of age. And it is, although it's a relatively rare cancer, it's often lethal because it's detected in later stages. And so actually the fourth leading cause of cancer death in women. And there are risk factors, the BRCA1 and 2 genes, the Lynch syndrome. The majority of them are surface epithelial tumors, and there are various pathologies, including serous carcinoma, mucinous cancer, endometrioid, and clear cell cancers. And look for ancillary ultrasound findings in ovarian cancer. If you suspect a mass is malignant, always look for ascites, and the ascites oftentimes can be complex. Look for, they spread with peritoneal carcinomatosis, so look for these solid implants, oftentimes you'll see them in the cul-de-sac. And you also look for implants around the liver or the spleen. So this is a patient at the bottom here at that history of ovarian cancer. She had omental masses, and she also had this complex cystic mass, which it was the edge of the spleen, just a tumor implant at the surface of the spleen. CT, of course, will nicely show the carcinomatosis as well, but you can see it on the same patient on the vaginal portion, the soft tissue thickening in the peritoneum in the cul-de-sac, which again is another image for carcinomatosis. Now, moving beyond ovarian cancer, there are other malignant ovarian lesion, ovarian metastases. Now, that represent about 10% of malignant ovarian masses. The primary cancer is often colorectal, stomach, the so-called Krukenberg tumors, pancreas, breast, or lung. And the clinical history is often key, and because these patients oftentimes have advanced cancer, they can be bilateral. But this is a patient that presented actually she had a CT scan, I think, for abdominal pain, and then we saw this on CT, this brightly enhancing mass in the right adnexal. So an ultrasound was performed, and this is the ovary here, the right ovary, and you can see on color Doppler, although the ovary is not very, very much enlarged, there is this disorganized flow with low resistance flow in this patient, and she had a Krukenberg tumor to the right ovary from a GI primary that hadn't been detected so far. This is a patient who had known colon cancer, and we can see bilateral. So I'm just showing you the left, but she had very large, multicystic, multiseptated masses in the pelvis. I'm showing the left ovary here, and she also had an echogenic mass in the liver. This is a patient who had mucinous colon cancer with metastasis to the ovaries as well as the liver. This is kind of a nice little case that I saw recently. So this is a patient who had a rising thyroglobulin level, and I will give you the history in just a second, but you can see here there are echogenic masses within the right ovary with increased flow, another mass on the left side here. And this patient had a history of metastatic papillary thyroid cancer in struma ovaries, and this was a recurrence, a very unusual case. Now, what happens with these masses? So this looks like a solid and cystic masses. There's some solid component, maybe the wall is thickened, so we're concerned about this. There is not much flow here. Okay, so really, this mass is perhaps a little bit more difficult to classify. She had an MR because we really were concerned that this could be a malignant lesion. It was also indeterminate on MR, and so these patients will have to go to exploratory laparotomy, and this was a mucinous cystadenoma. So there really clearly is an overlap between the benign and the malignant lesions, at least in some cases. So that gets me to the next topic, ovarian masses that do not fit the previous patterns. And one of them is the mass I showed you initially. So this is a patient who had a 57-year-old woman who has this mass in the ovary. Now, if you look at the left of the mass, though, it's very, very hypoechoic and there is shadowing. So if this was in the uterus, we would think this is a fibroid, right? So this is clearly in the ovary. So one of the things that you see, if you see a mass like this in the ovary, think about the diagnosis of ovarian fibroma. And that's what we suggested. And we recommended an MR to confirm. And you can see that on the T1 as well as T2, it's a very dark signal intensity, no enhancement. And this was confirmed by MR to be an ovarian fibroma. So in these cases, even though we can suggest a diagnosis, I think that, the patient really need a confirmatory study, and MR is great for that. So ovarian fibromas are stromal tumors, and among the stromal tumors, you have fibromas and thecoma, granulosa cell tumor, as well as serous tumors. And those fibroma have a pretty suggestive appearance, very, very hypoechoic, marked acoustic shadowing that comes from the dense fibrous strand within the tumors. And the main thing is to differentiate them for a pedunculated fibroid arising from the uterus, and again, as I said, MR for confirmation. Now, this is an interesting case. This was a 62-year-old woman with hirsutism and a high serum testosterone level. And when we do the ultrasound, so the ovary is a little bit lobulated, but really not enlarged. And I think in this case, again, color Doppler is very helpful. This is power Doppler is very helpful to determine where the lesion is, because if you see this portion of the ovary, it's very vascular with low resistance flow. But again, the history is key, and in a patient with hirsutism and high serum testosterone, you have to really think about the possibility that this patient has a benign sertoli lytic tumor, which, or at least a sertoli lytic tumor, the vast majority of which are benign, and this was confirmed at surgery. So this is a very good use of color to try to find lesions in relatively small size ovaries. Another use of color, of course, that I do is to differentiate to confirm whether a mass is cystic or solid. So if you look at just the grayscale, these masses do not look that much different if you look, very, very carefully. Of course, you're going to suspect that this is an endometrioma, and it's confirmed because there is only flow at the periphery. This mass, when I looked at it, I initially wasn't sure whether it was cystic or solid, but you look at the color and there is flow within the lesion. So of course, this is going to be a solid mass confirmed to be a fibrothecomite surgery, and this is going to be an endometrioma, the classic appearance. So to conclude, let me show you this case. So this is a 26-year-old woman with an adnexal mass, and if you look at the clip here, it's a predominantly cystic, but there is a papillary solid component right there. So in a 26-year-old patient, of course, you're worried that this is an ovarian tumor, but one of the things, this is a good appearance, a good age for one of these lesions, the borderline serous tumor in the right ovary. So these are borderline serous tumors, so they have relatively low malignant potential. This is another patient we were following. She had a right oophorectomy for an ovarian tumor of low malignant potential, and she came back, and then the other ovary, there is a much smaller lesion, but again, you can see this papillary kind of nodular solid component with increased flow, and so this was a borderline serous tumor in the contralateral ovary in this patient. So these represent approximately 15% of ovarian epithelial neoplasm. Histologically, mucinous are more common, but they can be serous. They don't have stromal invasion. The typical demographic group is going to be younger women, 45 or younger than 40 in one series. And the treatment is, at least to think about it, it's of course surgical resection, but there's a question of fertility preservation in these young women, so it is really a dilemma for the obstetrician, for the gynecologist, I'm sorry, but they have very good prognosis, 98% survival rate with majority of FIGO type 1 ovarian tumors. And this is a 56-year-old woman presented with a distended abdomen. And actually, she didn't have ascites. She just had this very large mass that you can see on the sagittal CT as well, the ultrasound with internal echoes, multiple septations, and this was a mucinous tumor of the ovary. This turned out to be a benign mucinous tumor. Now, are we always right when we talk about ovarian lesions? Well, let's look at this case. So this was an 88-year-old woman with abdominal pain. So she had the CT scan, and of course this angry-looking enhancing mass in the right adnexa with enhancing. So you're obviously concerned that this is an ovarian cancer in this older woman. We did the ultrasound. Not much different, just kind of looked a little funny, but there is not that much flow, but still solid and cystic component. The thing we didn't realize was, at the time, that this was very close to the loop of bowel here. And then it turned out at surgery that she had an appendiceal abscess with focal perforation and sort of a chronic abscess. So just something to keep in mind. I don't think we could have made the diagnosis with certainty prospectively anyway, and so she had to go to surgery. So in conclusion, in evaluation of adnexal masses, our duty is really to offer specific diagnosis whenever you can, and then determine if the ovarian mass is likely to be benign or could be an invasive ovarian malignancy, characterize indeterminate adnexal mass if possible, And because this really has critical management implication, because if we can offer a specific diagnosis of a benign lesion, you can either do nothing or follow up. If you're concerned that the mass is indeterminate, we recommend additional imaging, which really oftentimes will be MR. If you're suspecting that the mass is an ovarian cancer, then we need CT for staging. You would have appropriate referral if we suspect a mass is malignant to a GYN oncologist rather than a gynecologist. Also, if the mass is more likely to be benign, they may consider to start with a laparoscopy first rather than directly going to laparotomy. Consider preservation of fertility in younger women, and basically our duty is really to help tailor management to individual women. And I thank you very much.